It's fascinating, that first line data, and I think that it is motivating to all of us, even though it's a small subset of those patients and there may be some biases. How do you decide when you want to use a chemo induction versus a PARP inhibitor first, Adam?
For me, it's very interesting that, Brocade in a way speaks to that. And that's, so my idea is, I think a single agent PARP for now, in the absence of the Brocade data, would say give the single agent PARP and not do the chemo induction like they do in ovarian cancer. But I think that, as we're going to find out in a minute, talking about the Brocade data, that may kind of change people's minds a little bit about that.
That's interesting. And then, of course, there are other trials as well. So why don't we move on and talk about, well, just before we move on, one question is, you generally manage the anemia by reducing the dose. Has there ever been a situation where you've changed from one PARP inhibitor to the other, Ian?
Well, so I mean, that is an interesting, I mean, to me, it was striking. I think Adam alluded to the fact that from an efficacy standpoint, the drugs look so superimposable, olaparib versus talazoparib, exactly the same hazard ratio for PFS, almost exactly the same response rate. But they do seem to differ a little bit. It does seem like there's a little bit more hematologic toxicity with talazoparib. So I would, I think if you were having a patient who's on talazoparib, is having anemia as being a real significant problem, potentially switching. But in most cases, I tend to use olaparib, so it hasn't come up with me. On the other hand, someone's responding to a drug, it makes you worry a little bit about switching.
Yeah, although they do seem to be fairly similar. I have only switched in one patient really due to nausea, but I think that, it's hard to know. There do seem to be a little bit of differential toxicity. So it is a consideration if dose reducing is not effective. As you mentioned, Adam, there's a lot of new directions that were going on in using PARP inhibitors for breast cancer, both in the metastatic setting with a chemo induction type approach and in the early stage setting, as well as combinations with immunotherapy. You want to talk about those a little bit?
So again, I think that, there's a lot of really interesting things, in particular, kind of where to put the PARP inhibitor in the therapy itself. I think, we remember from our ovarian colleagues, they would give chemotherapy first to a maximum response and then add the PARP as maintenance. And there are survival benefits to that. So, that's never really been done in breast cancer, but at least we can get some hints on this from the Brocade trial, which basically was a trial where women had less than 2 prior lines of therapy, less than 1 prior line of platinum, and were randomized in a 2-to-1 fashion to veliparib, carboplatin, Taxol, or placebo, carboplatin, Taxol, and you could cross over to veliparib at progression. And again, the primary endpoint was PFS, and this shows you the data, and it's really fascinating. In this, and again, I think I personally would have used restricted means analysis, but they used PFS, and there was a PFS benefit. And the reason I would have used restricted means analysis, if you look very carefully at the curves, they seem to separate at about month 8 or 10, and that's a month or 2 after stopping the chemotherapy. So, to me, it suggests that you're not really getting a lot of benefit from the combo. I mean, I think people could argue differently, but that the curves really seem to separate when you have the maintenance of olaparib versus the placebo. And I think that's a really important subtlety here that hopefully I think we understand to a bit and argue about a little bit whether that's true or not. So this may argue for maybe chemo first and then PARP second. But again, the adverse events are kind of what you'd expect. The mean exposure to the carbo and Taxol it looks like was 12 months or 12 cycles, however that was defined. So people generally in both arms of the trial tend to get the same amount of therapy on study. And again, this just shows you pointing it out. At this point, you had 40% that were on monotherapy versus 34% monotherapy with placebo. And that seems to be where the curves seem to separate. It's after getting chemo, again, for 8 to 10 months, and then having that separation, you really see here that it really could be the maintenance, like our ovarian cancer colleagues have been seeing for many, many years with these agents. That may be really where all the efficacy here is. And this is just some other, kind of just talking a little bit about some other options that are on the table and are being considered. MEDIOLA was a trial of olaparib with durvalumab in mutated BRCA mutated breast cancer. Again, you had a run-in with olaparib. The idea being you kind of drive up some of these DNA repair issues in the cell, get a lot of new neoantigens being presented, and then you would get durvalumab to have kind of that immune effect. And, it looked kind of interesting. Hopefully we'll take that on a little bit further into phase 3 clinical trials. And so these are all the variety of phase 3 clinical trials in early stage breast cancer that are going on. There's the Olympia trial, which again is in maintenance treatment versus placebo in high-risk disease. And a lot of the high-risk disease tended to be women who had neoadjuvant chemotherapy and had residual disease. And I had a number of women on this trial in that exact setting. The partner study, again, is similar to what we're saying, olaparib with weak carbotaxol versus carbotaxol alone. Again, this is a trial that's very interesting. And then Gepar-Ola, you can see here a lot of neoadjuvant trials. There's trials of rucaparib with radiation, and then finally there's a trial which I really am fascinated by. This is a trial of single agent talazoparib that I believe is just about closed. It turned out that there was 20 patients that were trialed with talazoparib as a single agent for 4 to 6 months. Then all went to surgery, and chemo was given at the investigator's discretion after. And it turns out that the pathologic complete response rate, I think, was around 50%, and then maybe it was another 10 or 11% of patients that actually had RCB1, which is a pretty good prognosis. So this is really fascinating. And, it was interesting. I think the original trial design was 111 patients, but they stopped at 70 for some reason. And maybe one of you, if you know that, because I don't know why they stopped, and I'm really curious as to why they stopped the study. But again, I'll kind of go back to you.
I think that the plan was, my understanding is that their plan was to try and actually do a randomized trial and get a better understanding of who benefits. And so there was plans to do another study after this larger confirmatory single arm trial, okay. Which is interesting. And also there's a metastatic trial, Key-Link 09, that's looking at patients who've gotten an induction with gem-carbo pembrolizumab and then are randomized to receive either continued chemotherapy and pembro with stopping as needed for toxicity versus getting pembro olaparib as a combination regimen. So there are really a huge number of studies, even MEDIOLA and other trials are looking at treatment in patients who have HRD defect, et cetera. So we're going to see a lot of data in this area in the near future, and with our registration trials ongoing that will help us to understand the benefit of combining these agents, IO and Parp inhibitors in the future. And of course, we're very excited about seeing the data from Olympia eventually. So I think now we'll go on and wrap up our very interesting discussion where we've talked about a number of different cases and really covering all of the big areas in breast cancer. I'm sure we left some critical areas out, but we talked about HER2 positive disease. We've talked about hormone receptor positive metastatic breast cancer. We talked about metastatic triple negative disease. And then we talked about what to do in patients who have BRCA germline mutations with PARP inhibitors and where to use them. I'd like to thank our panel for your thoughtful case presentations, this lively and informative discussion, and in particular to Dr. Sadaman, Evita Sadaman, for joining us from the pathology side to give us an interesting perspective as well. To our viewing audience, thank you for joining us for this Targeted Oncology Virtual Tumor Board presentation. We hope today's discussion was a valuable use of your time, and we hope that you were able to acquire some practical knowledge that you can take back to your clinic. Thanks very much.